Hi everyone. I'm a nurse practitioner working at Salford Royal, and I work with the geriatricians in managing the care of older people that are admitted to hospital. So I'll give you a bit of a background of how I came to be in my current position and what it entails and what I've been up to over the last few months. So there's someone that's not on mute there and it's quite loud. I'll put myself on mute. That's it. So I'm a Rochdale girl myself. I went to Hopwood Hall College and I did a BTEC in health studies, and that's what led me into nursing. So I was a cadet nurse when I was doing my BTEC at the college, which meant I was able to spend 3 days a week working in ward placements in the hospital, and then 2 days I came into college and did my studying. And when I came into that course, I didn't really have any idea of what I wanted to do. I knew that I wanted to work in the hospital somewhere because that's what some of my family members do, but it's only through spending time as a cadet I was able to see lots of different areas, and I realised that nursing was the thing for me. So I then went on to do a diploma in adult nursing. That's been replaced now with a degree. All nurses are educated to degree level. I qualified in 2009 and I started my career working as a nurse on a coronary care unit at Fairfield General Hospital. And it was really interesting working there. A number of, 2009, a few years ago now, isn't it? The treatments for heart attacks and heart failure and things were very different. So we used to get really sick patients that came in to the coronary care unit that we had to look after. And we gave things like drugs. We had patients that had really life-threatening heart rhythm problems. Because we didn't have doctors covering the ward all the time, the nurses really needed to learn a lot about how we manage heart-related problems, so that if doctors did need to come and see the patients, we could guide them in the management of what needed to happen. So I learned absolutely loads when I was working there, and I really enjoyed it. But over the time that I worked there, changes started happening in terms of emergency heart attack management. So instead of giving clot busting drugs, we then moved towards doing emergency procedures called angiograms, where wires are put into the arteries either through the groin or the wrist, catheters passed up to around the heart, and x-ray pictures taken using dye so they could see where the narrowings are and open them up. And it's specialist centres that deliver that kind of service. So in our area it's Manchester Royal Infirmary and Wythenshawe. So what I found over time is I weren't seeing the same kinds of patients that I liked looking after at Fairfield. So I moved over to the Manchester Royal Infirmary, 12 months there, so I could get involved in the emergency treatments. I learned about how wires and balloons are put into the arteries around the heart to open the arteries up to help the heart pump. We use special means of ventilating the patients on the ward if they're not able to breathe properly for themselves. Learned loads, really hard work, really busy, but great. And then what happened then is from Salford Royal, they were looking for a heart failure specialist nurse. So I was asked whether I would like to apply for that. I said yes, of course, because that was always my interest when looking after the patients on the ward. Heart failure patients, the heart's not pumping well enough to get the blood around the body, and they get lots of symptoms as a result of that. So I moved over to Salford in 2014 to become a specialist nurse in heart failure. And the responsibility I had there was to see patients in a clinic. So I had responsibility for a new patient clinic. So what would happen is a patient would be given a diagnosis of heart failure. It's quite a scary thing for patients to be told that they've got heart failure. Lots of them think that they're going to die imminently. That's not the case. It means the heart's not pumping as well as it should. And there are treatments that we have available to us to help them feel better and live longer. So the patients would come to me from a cardiology clinic. I'd spend an hour with them going through what the diagnosis means, what's caused the heart failure, what treatment options are available, and how that patient then needs to manage themselves at home from a fluid balance point of view, taking the right medications. I would then see the patients again after that in follow-up clinics. So there's different reasons why someone might get heart failure. the biggest causes after a heart attack. So there's reduced blood flow to the heart muscle, so the pump becomes weak, so it can't work efficiently to move blood around the body. And what we know from big studies is that there's certain medications that can help support the heart pump function. It helps patients feel better. It also helps them stay out of hospital, and it improves their life expectancy. So it's really important to see these patients regularly to up the doses of the medications to give them the best support. So part of the requirement for me to fulfil that role was to undertake some extra studying at university. So I did a non-medical prescribing course so that I could prescribe and change the medication doses. As I said, I've qualified with a diploma in nursing, and what I did over the course of the first 4 or 5 years of my career is topped that up to a honours degree, and then I started a master's degree, so the prescribing was part of the master's degree. Although nursing is not as accessible as it used to be, when I trained, all our fees were paid for us and we got a bursary. That's not the case anymore, unfortunately. But once you become a nurse or any healthcare professional, you do have access to monies through the hospital so that you can take on extra courses. So I've been really fortunate in everything that I've done. I have been funded by the trust that I've been working for at that time, which has enabled me to do lots of extra studying and get extra qualifications. So in terms of the prescribing, that's something that I did when I started the job. So we increased the medications to help patients live longer. Someone who's newly diagnosed with heart failure is about 30% of them will have died within 12 months and 50% will have died within the next 5 years. So it's really important that these patients get seen by a specialist quickly. There's other reasons that someone might have heart failure, and that might be related to high blood pressure or heart valve problems or irregular heart rhythms. So the idea of the heart failure nurse is to address all of them problems, target the interventions and the medications to the problem that's causing the heart failure, and hopefully keep them out of hospital and feeling well. I also had responsibility in that job for all the patients that were admitted to hospital with heart failure. Usually because the breathing's really bad, or they've got lots of fluid and swelling in the legs, which limits their ability to get about and do their normal activities. And what they need is strong medications, usually through a drip, to help us get rid of the fluid. So I would see all the patients that came in to hospital, and usually most days as well. I got quite involved in managing the care of the heart failure patients. It's quite different to when I first started out in my career, where I worked on a ward with a team of nurses. There was always someone more senior than me around that I could ask for help, or my colleagues that I were on shift with. You know, what would you do? What do you think to this? Should we get the doctor? What could we change about this to make this better? So as a heart failure nurse, I felt a bit overwhelmed by sort of the decisions that I needed to make, and the level of education. Although I'd done lots of extra training, it weren't quite up to the level that I needed to do that job, which is what led me into thinking about progressing towards becoming an advanced practitioner, because that's an extra master's level programme that you have to undertake in order to work as an advanced practitioner. At the time that I decided that I would do that, there were no jobs in cardiology, but there were jobs advertised in geriatric medicine, so working with older people. And all the way through my career, I've only focused on people that have got heart problems, so it's a big decision to make about whether to apply for this new job or not. It turns out actually it was the best thing that I could ever have done, and I absolutely love working with older people because they've got so many different things wrong with them, and they're all so different to each other. What somebody thinks is really important for their life, their quality of life, is completely different for somebody else, and the variation keeps me on my toes every day. So I did the Advanced Practice Masters at the University of Salford, so that's 2 years. I have a consultant geriatrician who's my supervisor, and what it meant is I were working a couple of days in the hospital alongside him, seeing patients, learning how to assess, diagnose and manage the problems that they were coming into the hospital with, whilst also doing lots of extra modules around clinical examination of patients. Other people that weren't already prescribers needed to do that. And then learning about the treatments available for lots of different health problems, how we manage them, and when we need to refer on to a specialist for their input. So there's a lot of hard work, but I definitely got out of it what I wanted, which was the extra added level of knowledge, to the point that when I qualified, I now work sort of alongside the doctors within the medical team, see patients by myself. So if they come in, I can assess them, take a history from the patient, try and work out what I think's going on, what might the diagnosis be. I can order all the different tests that they need, so blood tests, x-rays, CT scans, MR scans, review the results of them so I can work out what the problem is and then prescribe the medications that they need to help them get better. In particular, thinking about older people, lots of older people need help with managing their own health needs. So a huge aspect of my job, right from the moment that patient comes into hospital, is to start thinking, how am I going to get this person out of hospital, ideally back to their own home? What kind of support are they going to need? Is that carers? Is it nurses? What follow-up are they going to need? Is it manageable? And if it's not, then thinking about what the alternatives might be. So unfortunately, some people that come into hospital from their own home will have deteriorated so much during the course of the illness that they need to go into a residential home or a nursing home. So it's thinking about that kind of process as well. Since I qualified, initially I worked only on the medical ward, so seeing people that had come in with things like pneumonia, kidney disease, heart attack, diabetes, falls, confusion. But my supervisor and another one of the geriatricians deliver an in-reach service to general surgery. So all patients that come into hospital with an emergency surgical problem that are looked after by the surgical team, and all patients that come in for an elective operation, a colorectal or an upper GI operation, we deliver a service where we see the older patients alongside the surgeons to help guide the management of the medical problems that they have. Patients that come in and have an emergency operation, we're part of the process of assessing whether the person's fit enough to undergo the operation, asking them, is that what they want to have? Because we know that older people that have operations do really badly compared to younger people, and they often end up needing extra care. They might end up with a stoma that they find really difficult to manage and that can cause them problems in the future. So it's really about trying to work out in each individual case what's the right thing to do. So that's kind of become my area of expertise, and what it's allowed me to do is branch out a bit into education. So I teach, and just before I joined you on this call, I was in a call with people nationally that are looking to set up similar services to the one that we have at Salford. So I'm able to educate them and advise on how they might replicate what we do. Because at Salford we are recognised as being one of the best in the country for the service we give, which is great. And also research. So I've been able to get involved in lots of research around outcomes for older people that come into hospital. As I've said, they do much worse than the younger people, especially if they're frail. So frail might be a term that you've heard said in the news quite a lot recently over the last few months. Older people, frail people have sort of been light with COVID and everything that's been going on there, because they do badly. If they catch COVID, they're much more likely to be admitted to hospital. They're more likely, unfortunately, to die. And if they do recover from the illness, they're more likely to need lots of extra care when they go home. So we know frailty is a big deal in surgery, and it definitely influences how well a person will manage after an operation. So we've done some research into that on a smaller scale, and we're looking at expanding that now. And advanced practice, as I am an advanced practitioner, is made up of 4 different pillars. So they're called the pillars of advanced practice. So clinical is a big one, and that's what I do every day, day in, day out. Then there's leadership, education and research. So in order for me to practice at the appropriate level for my qualification, I need to be working across all them 4 pillars. So I've become more involved in research over the last few months. Because of sort of personal circumstances for myself, I've not been able to see COVID patients in the hospital face to face. So I've had to do a lot of remote working, which has worked out all right. So what they say is usually when a patient has a problem, the history taking, so asking them questions about what's wrong and what's been going on over the last few weeks and what symptoms they've been having, helps you to reach a diagnosis 80% of the time, and the examination itself is just an added 20% to that. So having electronic records at Salford, I've been able to look through them and help my colleagues on the wards in assessing the new patients by doing it remotely. But it's also freed up quite a lot of time because I've not been able to go down onto the wards and do the usual stuff that I would like, discharge planning meetings and education sessions with the ward teams. So thinking in terms of COVID, I've been able to get involved in a really big trial, a big study that's happened. We looked at patients admitted to hospital during the first wave in April through to June. So it's an established research team that have done some work previously in frailty and surgery. And what we decided to do is look at frailty and COVID and work out, well, try and determine how frailty influences outcomes for the people that come into hospital that are positive for COVID. It was a big study, and it was published in the Lancet, which is a really esteemed medical journal. So I've been extremely fortunate that I've had the time and the right people around me to be able to get involved in that. And what we showed is, yes, frailty does influence outcomes for older people in COVID, and it means they are much more likely to die if they're admitted to hospital. So I know you've probably heard it from every angle recently, especially with the rates that we have here in Rochdale. But it is so important that you follow the rules and the guidance. For yourselves, it might be that you're asymptomatic or you just have mild symptoms of COVID. If you pass that on to your friends, or your friends pass on to relatives, and that reaches an older person in your social circle, that older person is much more likely to have a poor outcome following a COVID infection. So definitely wear your masks, wash your hands, stick to the rules. We're all stuck at home from tomorrow anyway, aren't we? So yeah. So I've said the word frailty quite a lot, and I want to just explain what I mean by that so you understand. It's not frail as in we perhaps think about people being thin or lacking muscle. It's what we call a multi-systems syndrome. So that means multiple parts of the body, multiple processes in the body are affected. Syndrome means it's a set of symptoms or problems that a person has, and it predisposes them to worse outcomes if something such as an illness or an injury comes along. So we've seen this in older people that we class as frail, using a scoring system. So there's different frailty scoring systems around, but commonly used ones say not frail at all, number 1, this person's very active, goes out exercising all the time, all the way through to 9, where this person is extremely frail and they are dying. The higher the frailty score for a person, for example, following a pneumonia or a heart attack or an operation or a fall, they're much more likely to die, they're much more likely to have lots of problems after that, and they're likely to stay in hospital longer and need more care when they go home. So it's definitely something as a population that we need to be more aware about, and I'm sure you've all got an example of a family member or a friend of the family that you can think of and think, yes, that person fits into that sort of description of being vulnerable, at risk. And they're the patients that are my bread and butter that I see every day. So the older and the frailer, the better for me, because that's where my specialist skills lie. And you might ask then, well, you've told us lots of things that you do that are quite doctor related. So you work with the doctors, you've done research with doctors. Why is it that you're a nurse? I think that would be an extremely good question. I would be paid a lot more money if I was a doctor. Unfortunately, I don't earn quite as much as them. But what I found throughout my career, right from being on the ward, I was a nurse on coronary care unit, I would have maybe 1 or 2, a very maximum ever, 4 patients to look after per shift. And so what that allows me to do, or allowed me to do, was spend the majority of the time that I was on that shift with that patient, helping with what they needed to do, educating them about the problems that they had, what they needed to do to look after themselves, both in the hospital, once they get home. Lots of times patients would receive bad news or a bad diagnosis, or sort of news that their life might be limited by the problems that they had, and that would usually back then be given by a doctor. But what I found is the doctor would come in and give the information very well, but then they have to leave and see the next patient, and it's the nurse that's there afterwards when the patient's scared, has questions, they're upset. It's the nurse and the nursing team that are there to reassure them, to be there for them. When they can't wash and dress themselves because they feel too unwell, again, it's the nurse who's there to help them do that. The nurse who's there to help them feed themselves when they can't do it for themselves. And you really get to know the patients extremely well, patients and the relatives, and you get a true sense of what it is that the patients want, what they desire, what their expectations are, what you can do to make their life better. And that's the part of nursing that I love the most, and it's something that's carried through all the way through my career, from being a ward nurse to then being a heart failure nurse, where, as I said, life expectancy is limited, the patient's at high risk of coming back into the hospital. Through spending that extended amount of time with the person, you really get to know them and get to know what their priorities are, so that you can plan the care around that on an individualised basis. And I've made sure that I've carried that through now into my current role. So although I work with the doctors and I do very medical things, I always rely on and lean back on my nursing background, communication skills, working within a team. So older people have lots of problems, not just physical problems. They might have problems with their mobility and their function, in how well they can wash and dress themselves. Can they make meals for themselves? Do they need help with the shopping? So that's where people like the physiotherapists and the occupational therapists will come in. Social workers are really important. Lots of people that come into hospital have confusion, so what we call delirium. So it might be that the mental health team need to get involved. And as a nurse, MDT involvement and coordinating care like that is a huge aspect of your job. And that's something that I've managed to keep in my role now. End of life care is another big one. So follow through from being a heart failure nurse to now. Older people, by definition of being older, are closer to death than younger people, and people that come into hospital who are frail are more likely to die. And just itself, coming into the hospital with any acute problem increases the risk of dying within the next 12 months hugely. So a third of all people that come into hospital with an acute problem will not be alive at 12 months. And in the over 85s, that's about half of them won't be alive. To think then that they might have lots of things that are wrong with them that limit their ability to enjoy life, get around, go out, look after themselves. It's really important that we take the opportunity to find out what we can do to make that time that they've got better. So something we call advanced care planning is a huge part of my role, working out what it is that that person would want at the end of their life when it comes. Again, this is something that we're not overly keen on talking about as a population. There's been lots of bad press recently about resuscitation discussions, care home residents and advanced care plans in COVID. Some accusation that resources have been denied to older people just because they're old or they're frail. And that's not the case at all. In lots of instances, it's highly inappropriate for an older person to come in and be admitted to an intensive care unit and have a ventilator doing their breathing for them, because they're never going to get better if that was the case. So I think as a population, it's important that we clarify exactly what it means when we're having them kinds of discussions, and that we do talk about it with each other. You'd be surprised, older people often have thought about it. They might not have told anybody about it, but they do know, mortality is something that we all die in the end. And as we get closer to that, you do think about it. So when we ask patients these kinds of questions in the hospital, they're usually not surprised by it, and they usually already have had some thoughts about it. So if I were going to give you any homework following this session, it might be to think about people that you know, family, friends. Do you know what they'd want in the event that something catastrophic happened? Would they want to be resuscitated? Would they want to go onto an intensive care unit and have a tube down the throat to do the breathing for them? For the older people, probably not. Younger people, like the ones that I used to look after on the coronary care unit, in a younger person, if the heart stops beating or the breathing stops, it's usually because there's a clot somewhere in the body. So in the heart with a heart attack, or the lungs, or in the brain, as in the case of a stroke. And we've got new fancy high-tech technologies and interventions available to go in, quickly resolve the problem, get rid of the clot, get the heart beating again, and that person will survive and be as well as they were before the event. For an older person, especially a frail person, they're not fit enough to have interventions like that. So there is no easy, quick fix to the problem. They've often got lots of other things going on as well. So it's sort of drilling down to the bottom of all that and what the person would want seems to be a huge part of my role. I can't say it's enjoyable as such, but it's really important, and it gives me a lot of satisfaction to be able to create a plan with that person for the future. It's one of the last things that we can do for somebody in their life is help them have a successful death. So I see it as a success in that sense. Going forward, unfortunately, we're now going into a second wave, aren't we? So the hospital's getting much busier again. We've lots of patients that are tested positive for COVID. So over the last few months, I have been able to go back into hospital and see my surgical patients again. But now, unfortunately, I'm not going to be able to do that. So I have to find alternative means of keeping myself busy. One of the things that I have been doing is the research I mentioned. We're starting that study up again next week, so that's going to be keeping me busy. I've started another master's, again paid for by the trust, so I've been lucky in that, but this time it's a research based master's with the hope that I will be able to progress on to do a PhD. So I've been putting a proposal together for an application form for the National Institute of Health Research to see whether I can be awarded a grant to enable me to do that full time. And that's, I think, a really important point to make about nursing. Sometimes the nurses are seen as the caregivers and the doers and sort of not getting involved in the bigger picture and the overall management, and that's absolutely not the case. We've seen over the last 50 or 60 years the nursing role has changed phenomenally, from myself, who qualified with a diploma, and now that's obsolete and you have to be educated to degree level even to become a nurse, and some people might have done a degree in something else first and they can become a nurse through doing a master's programme. So it's really important that as nurses we push forward with the developments that we've made. We now hold positions in sort of key organisations, key funding bodies. Lots of nurses go on to become academics, working in the universities, getting involved in big research projects, and that's what I'd like to do. Is a study looking at the experience for older people after an emergency operation, thinking, as I've mentioned, that they do much worse than younger people. What can we do to make that experience better for them? So hopefully I'll be able to start that within the next 12 months. I've also been writing for lots of journals or papers for nursing and medical journals on how we can look after older surgical patients better. So although I'm not able to be there on the front lines on the wards looking after the older people face to face, I'm doing my best to keep going in the background and putting out the necessary information to help us look after them better in the future. So I'm conscious that I've spoken for quite a lot and I've told you quite a lot of things. I'm more than happy to answer any questions based on anything that I've said or anything else that's popped into your head.
Thank you for that, really interesting. Guys, if you want to ask questions and you don't have access to unmute your mic, if you type in the chat box, I can read them out. I don't know if you are able to unmute yourself. What I'll do, Angeline, if it's okay with you, because obviously I've got Gareth's email address. If any questions do come through to me, I can always forward them on to Gareth in a collated email.
Yeah.
Is that all right?
Sounds good.
They normally have the mic and camera option removed as students. So
okay.
I'll tell them, if anyone emails me any questions, I'll get them sent over to Gareth.
Yeah. I think there is something in the chat box.
Oh, we have got one in the chat box, yeah, from Fatima.
Is an advanced practitioner similar to a physician associate?
Oh, sworn enemies. We are sworn enemies. Yes, we are quite similar. The difference being advanced practitioners tend to be experienced clinicians, such as nurses or physiotherapists, occupational therapists, dietitians. They're people that are already working in a profession and have been for a number of years. The criteria when I applied to become an advanced practitioner was I needed to have 5 years experience working at a senior level in the hospital in order to be taken on for the training. Whereas a physician's associate tends to have done a medical related degree like biology, biochemistry, etc. They then do a 2-year programme working alongside the doctors in the hospital environment or GPs, etc. We're similar in the way that we work, in that we're there to complement the medical team. What I found and my experience with physicians associates is only over the last couple of years, because there's sort of a new thing coming through. What I bring from my nursing background and the experience that I have gives me an advantage, or gives the patient a better experience through me than a physician's associate. But I'm sure once these people have been in that role for a number of years, they will also develop that clinical expertise and there won't be much difference between us. At the moment, physicians associates are not allowed to prescribe medications and order investigations, but again, that's probably going to change in the future. But when I'm with my supervisors, they're 2 geriatricians, I say we're a good team, but we're a good team because I'm a nurse and they're doctors, and together we're a better package. So I'm always going to say that advanced practitioners are better, but they're both very, very good jobs. And I wouldn't dissuade anyone from going down that route if that's what they wanted to do.
Thank you. Good question, Fatima, as well. Anyone else, any questions they'd like to ask whilst we've got the opportunity? Well, thank you very much for your time, guys. Really interesting, really informative, and I'm sure they will have taken a lot from that.
Yeah, power to the nurses for the future.
Thank you, Angeline.
All right, thank you.
Thank you.
Take care, everyone. Bye-bye.
Cheers,
Bye.
thank you. See you later.
Bye.
Right, guys, if you want to get logged off and if you have any questions that you wanted to ask me, please feel free.